So good afternoon, everyone. I want to start out by saying that as an Airway Innovator session, that first of all, I am certainly not an innovator. I'm not an expert, and I've probably not had an original medical thought in my life, but I'm able to follow instruction quite well. And Bill, who is probably one of all of those things among the others that have been up on stage, has put together some useful tools, and we have a little presentation here about the use of ketamine in fibre optic airways. And as Adam Rehak came up and showed us a few techniques before, I think this is in a similar sort of vein. It is a few techniques which can be used in specific circumstances that may not have been really described or talked about in too many other circumstances. So is worth having a bit of a video and a bit of a talk about. So Bill Bestick, as you can see, is online with us to answer any questions towards the end as well. Unfortunately, wasn't able to make it today. But Bill's had an interesting history, as a lot of the people we've had on stage today, and has a history as obviously an anaesthetist, but also trained in emergency for quite some time. Is currently an accredited helicopter pilot and worked in the Defence Forces for some time and security before this. And so it comes with a unique perspective on potentially innovating or using new methods within airway management, as well as putting together a really excellent resource in his book, which is called Who Plans Wins, which there'll be a QR code and some demonstration as part of the video. So in terms of what we're going to be talking about today, the ketamine fibre optic is something that Bill has been doing for some time after coming across some opposition to using ketamine as potentially a sole drug in this sort of area, and investigating whether or not it was going to be a potential or applicable medication to use as an adjunct or a sole medication in fibre optic manipulation. And I guess, as Adam said, it's not, with his techniques, this is not a replacement for awake fibre optic intubations in the indicated patients, but for patients, we would like to be cooperative and compliant. And when I say that, I mean in the anaesthetic sense, where they lie still and don't move at all, as opposed to potential other interpretations. And when looking at the potentials, there's been talk that potentially ketamine isn't the right drug. It can't be used for fibre optic intubation. It can make the airways more reactive and not be suitable for the placement of an LMA or having instrumentation of the airway. Can increase secretions and can make patients more combative. But in Bill's experience, and when I've seen it used in the right way, we can find that most of these things can really be overcome. And in this way, we've seen about several hundred fibre optic airways with ketamine without any major complications of note. And those sort of things that we thought we might come up against, or that Bill thought he might come up against, have been proven to be either not an issue or something that we can offset or improve. And so the two main options that Bill describes are the ketamine fibre optic intubation and the LMA to ETT spontaneous breathing techniques. And some people may describe them as awake techniques, but they're not really. In these cases, they're spontaneously breathing patients, which allows us some freedom in terms of the patient maintaining their own airway, but still the ability to get in there without a patient being combative. Important points are the pre-medication with IM glycopyrrolate as early as possible, and usually Bill will recommend taking the glyco down to ED or wherever the difficult airway is and bringing them up to theatres and giving it to them on the way or as soon as you can. And that's to offset, obviously, the secretions in the upper airway. And the ketamine dosing is something that should be done to allow for dissociation. There could be a whole talk on local anaesthetic and use within topicalisation for awake techniques or spontaneous breathing techniques. That's everyone has their own ideas on it, but Bill, and you'll see in this video, utilises 10% and has high flow oxygen to help disperse that. And there's some other tips that come in the book. So this was a real case that the patient has allowed us to use this photo. That Bill has used this technique on, and essentially it was a motor vehicle accident and sort of that horrible picture where we have unstable upper, the maxilla as well as the mandible, There's a lot of blood around, a lot of instability, and also had cervical instability. But unfortunately, the patient was uncooperative. And so utilising ketamine when a patient is non-cooperative for an awake technique is what's proposed here, while maintaining a spontaneous breathing patient to allow for oxygenation on their own. As I said, this wasn't filmed, so we have a video which will come up and we'll have a quick look through that. It takes a few minutes and runs through both the checklists that come from Bill's book, which are a useful sort of learning tool and help in this and other airway procedures, but also the technique itself. So if we can run the video. So again, it shows the same patient as an example of who this could be used on. And this is just a quick run through of the whole technique with the 360-degree camera. And you can see there's quite a few operators, and this is going to be in the operating theatre as opposed to the emergency department, but potentially could be done there. And the patient himself is spontaneously breathing and allows the LMA to be put in. And then after video-assisted placement of the Aintree and then a Cook airway exchange catheter, which is used as a conduit, the LMA is taken out, and then the endotracheal tube is placed over the top of that conduit. After this, it's going to show step-by-step sort of analysis of how you might do that. So as I said, Bill's book is Who Plans Wins, and you can get that on the Apple Store as well as Android, and it's continuously updated and has links to both videos as well as checklists, which are obviously very useful, and especially for people who are doing procedures that maybe they're not doing every single day, and to make sure that there's not a pertinent step that's missed. And so you can see there's a number of techniques that he has there, and you can just choose which one it has. It describes a few of the sort of indications for it, a brief summary, and then has a very detailed list of who needs to be involved, what you need, and then an actual checklist of step-by-step how to do it. So in this patient, obviously, this patient has given us permission to use his face and the case, of course, and the video will be put up potentially as a part of the book, but with blurring of the face. So we ask that none of this gets shared, but the patient has given consent to it. And of course, there's the plans as we've talked about before. So a bit in the mouth and then through the nose with a high flow to help aerosolize and push that down towards the pharynx. And then a little bit of fentanyl just to reduce the respiratory rate down to less than 10. But as you can see, it's quite small doses, 10 to 20 mics at a time, followed by some ketamine.
Holy crap. Whoa!
So as Bill says, it needs more ketamine. So he's potentially going to be competitive there, and giving some more in moderated doses gets the patient dissociated but still spontaneously breathing. So with gentle advancement, the patient tolerates the LMA going in, and without the use of propofol and with spontaneous breathing, the patient actually swallows the LMA and it sits very well in the posterior pharynx and continues to spontaneously breathe without any signs of laryngospasm or airway irritation.
The internal diameter of a tree and whole plastic are the same.
So he just swallowed it then and it came out of the operator's hands.
And the licorice?
We want minimal flex on that. So we get some.
If we're getting CO2 in there. We've got CO2.
And that's the patient spontaneously breathing on the bag.
Ready?
I'm going to give a little bit more ketamine. Just
a little bit of local anaesthetic down to reach the cords via the LMA.
And we can put that circuit back on, it'll go down. You might cough a little bit.
Yeah, it'll just stop there. That's okay.
Okay. Okay. Wow.
It's okay.
And so again, just tolerating an LMA in a sedated patient or a spontaneously breathing patient. So using the fibre optic scope, which is available in most anaesthetic departments with the Cook and Aintree exchange catheters, the Aintree loaded on top of the fibre optic scope is then placed under direct vision.
You need to take off the Aintree. Yeah. You hold that view. I'll take off the Aintree. Doing well. Okay, come in. Cook exchange.
But the Aintree itself isn't long enough to be able to hold both ends of the LMA and take it out without the potential displacement, and so the Cook Airway exchange catheter is placed.
Now we'll take all this off. Hang on. Let's not lose this. Yep, now you can take it out. I'll get you, we'll lower the bed, and you come to the head of the bed. Yep.
So now if this was that case with a severe trauma, you have a conduit to the airway with a patient that's been oxygenated, still spontaneously breathing, and then placement of the endotracheal tube has a definite conduit, and you have a fallback of the LMA to be able to go back in there with the spontaneously breathing patient.
24 at the lips. Okay, great.
All goes. We're on the ventilator?
You're on the vent?
Yeah.
Okay, great. We're
Okay, so that's the video. We've got Bill online now who is willing to sort of field any questions if there were about it, or where it's been used before, or how we got to it. And if you're keen, that's the QR code to get to the book on Apple Play Store.
I think seeing as he's made the effort to dial in, we should ask him one question, shouldn't we? Who's got a question? There must be a question about that. Here comes someone. Someone on the move? Is that one on? Is that one on?
He can't hear you.
I just wanted to know what the frequency and dosing of ketamine is and what you're titrating to in order to get to that state.
So-
Basically, without actually going over.
So Bill, I don't know if you heard that. He is asking what the frequency and the dosing of the ketamine was and what the sort of end target is.
Good question. So I usually start with 40 milligrams of ketamine just to get things moving, and then giving it a good 2 to 3 minutes to work. So as you know, ketamine's got a slow heart rate, circulation time. So I usually set my stopwatch to keep an eye on it, because otherwise I'll just be in too much of a hurry. So 40 milligrams, wait 2 or 3 minutes, and then usually 20 milligrams at a time until they're completely disassociated. So the end points would be horizontal nystagmus and totally unresponsive. If you start to do something with their oropharynx and their hand comes up or they wince, pull back, give another 20 milligrams, wait another 2 minutes and try again.
Happy with that, Bill? Big thumbs
Usual dosing for a dye like this would be in the order of 140 to 160 milligrams.
Thank
if
you.
that helps.